Okay, I think we can start. So, hello everyone, and welcome to our philosophy and psychiatry seminar. And I see that people are coming into Zoom, so we can start right about now. And it is my pleasure to introduce our today's guest lecturer, Justin Garson, who is a philosopher at the Hunter College and the Graduate Center of the City University of New York. His most recent works, a book, is called Madness, a Philosophical Exploration by Oxford University Press from 2022, and The Biological Mind, second edition from Routledge. And he's writing, and another forthcoming book is coming called The Madness Pill, The Quest to Create Insanity, and One Doctor's Discovery that Transferred Psychiatry. He has also contributed to psychologytoday.com and Aeon and medinamerica.com, for example, on changing paradigms of mental illness. Today, Justin is going to talk about a very controversial and interesting topic. It's called Beyond Psychiatry, Rethinking Madness Outside Medicine. So, Justin, the floor is yours, please.
Great, thank you so much. And I'm assuming you can hear me okay. Just, let me know if me know if you can't.
Okay.
Thank you so much for inviting me to speak. I wish I could be there in person, but as you can see, the title of my talk is Beyond Psychiatry, Rethinking Madness Outside Medicine. And I'll begin with a thesis, and here we go. I won't give you the argument for the thesis quite yet, but then I'll come back around to the argument. And the thesis is this: I've been investigating for some time the difference between what I'll call function and dysfunction framings in psychiatry. And I've been advocating for a shift from a dysfunction-centered to a function-centered framing. Now, I used to think that advocating for a shift from a dysfunction to a function-centered framing was really to argue for a kind of pluralism in psychiatry. It was a way of arguing that psychiatrists should be more open-minded. Sometimes they should use a function perspective, sometimes they should use a dysfunction perspective, but more recently, my thinking on the topic has started to shift. And I've started to think that psychiatry is, as it were, inherently wedded to a dysfunction-centered model. And that's because that's part of what it is for psychiatry to be a branch of medicine. So if that's right, then to advocate for a shift from a dysfunction to a function-centered point of view on psychiatry is not really to argue that psychiatrists should be more open-minded or pluralistic. It's really to argue that we should go beyond psychiatry or beyond medicine in the way that we think about mental illness. So I'll first start by saying something about what I mean by function and dysfunction perspectives, and then I'll go on to say something about this somewhat vague notion of the authority of medicine, and then I'll come back to argue for my thesis and raise a potential concern. So what do I mean by function and dysfunction perspectives? Well, over the last several years, I've come to think that you could look at psychiatry's history not so much as a clash between biological and psychological perspectives, but really a clash between what I call madness as dysfunction and madness as strategy. And the basic idea of what I call madness as dysfunction, the basic thesis or axiom is this: that when someone is mad, something inside of them isn't working the way that it's supposed to, something isn't working the way that it should. What we call mental illness happens when something inside the person has broken down. And if that's right, then the job of the doctor is pretty straightforward, at least from a conceptual point of view. The doctor's job is just to figure out what broke down and to fix it. Now, I want to be clear that what I'm calling madness as dysfunction is not the same thing as the biological perspective. It's not the same thing as taking a biological perspective. And that's because the thing that breaks down inside of you doesn't have to be a biological kind of thing. It could also be a psychological, kind of thing. So it's true that if you describe somebody's depression as resulting from a chemical imbalance, you're describing it in terms of something biological that's broken, that's not working the way that it's supposed to. But you don't have to do it that way. Freud, for example, had this whole theory of psychological development, and there was the oral stage and the anal stage and the phallic stage. And he thought that some mental health problems happen when somebody gets, as it were, fixated at a certain stage of development, the anal stage of development. And that, too, is a way of depicting mental health problems as the result of something inside of you that isn't working the way that it's supposed to. So again, an important part of these madness as dysfunction framings is that they're neutral between biological and psychological points of view. Now, there's this other framing. Oh, let me just say this. I do think that what I'm calling the madness as dysfunction framing is very deeply entrenched, not only in psychiatry, but also in popular thinking about psychiatry. And so one of my roles or tasks as a philosopher of psychiatry is not only to, as it were, expose how deeply embedded this particular framework is in psychiatric and popular thinking, but also to help craft new, perhaps more empowering ways of thinking about mental illness. So this brings me to a second framework, which I call madness as strategy. According to this framework, when somebody is mad, everything inside of them is working exactly the way that it's supposed to. Everything inside of them is working exactly the way that it should. So you can talk about this difference in terms of function versus dysfunction perspectives. You could talk about it in terms of purpose versus pathology perspectives. You could talk about it in terms of design versus disease perspectives. And instead of giving you a kind of tour through psychiatry's history, I'll just use 3 or 4 quick examples to give you a sense of how these ideas work. So consider depression. Since the 1970s, 1980s particularly, it's been very common to see depression as something like a breakdown of the sadness mechanism. So the idea is that there's something in your mind. It's designed to feel sad when something bad happens to you, but sometimes this sadness mechanism can break down. You can feel sad for no reason, and that's what depression is. Depression is effectively, according to this point of view, a breakdown in your sadness mechanism. But there's an alternative or function point of view, which sees depression itself as having a function or purpose. One idea is that depression is actually an evolved mechanism to help us to become aware that there's something in our lives that isn't going well and needs more attention. And I think if that's right, that would have very far-reaching implications for research, for treatment, for stigma. Another example is what's sometimes called borderline personality disorder. This is associated with a number of traits like being deeply mistrustful of other people, having a hard time being in intimate relationships, impulsiveness, sometimes self-harm. BPD is often described as the result of some kind of a frontal lobe deficit or some kind of a breakdown in executive functioning in the brain. But another point of view, what I'm calling this function point of view, sees the traits associated with BPD as survival strategies, not as brain defects. So there's recent work that suggests that the majority of people who are diagnosed with BPD have a history of abuse, neglect, or trauma. And if that's true, then it makes it much more plausible to think of some of these traits like being intrinsically extremely mistrustful of other people as being survival strategies, as being ways of dealing with a genuinely hostile environment. And if that's true, again, the solution would not be to treat it as a brain defect, but to try to help the person see how the strategies that made sense at one point of their lives might not make that much sense anymore. Delusions, these are beliefs that do not have social sanction, typically seen as very bizarre beliefs. You know, I'm the second coming of Christ, or I'm constantly being monitored by cameras. Surely you might think delusions stem from brain dysfunctions. But again, there's some recent research. I would think of this as a function framing, which sees delusions, at least some delusions, as maintaining themselves precisely because they give the person a powerful sense of meaning, significance, or purpose in life. And again, if that's true, that has deep implications for therapy, because it means you don't want to attack the delusion as if it were the disease. Rather, you'd want to provide some kind of alternate frameworks for helping to give the person a sense of meaning in life. One more very quickly, dyslexia, often described simply as a disorder of reading and writing. There's some evidence accumulating, however, that it's not a disorder, not just a disorder of reading and writing, but it's actually a unique and potentially evolved cognitive style that has its own strengths and its own trade-offs. So, for example, people with dyslexia tend to be very good at big picture thinking. They also tend to be very good at coming up with multiple solutions to the same problem. There's some evidence that up to 1/3 of American entrepreneurs may have dyslexia. So if that's right, then I think we're probably doing more harm than good, convincing, hundreds of thousands of kids, if not millions of kids, that their inability to read and write well stems from a brain defect, rather than representing a distinctive cognitive style with its own strengths and its own capacities. Okay, so I've said a lot about the difference between function and dysfunction framings. Now I want to say something a little bit more abstract, which is about the authority of medicine and why I suspect that the authority of medicine is somehow tied to these dysfunction framings. So the basic question I want to ask is this: what is it for a mental health condition to fall under the authority of medicine? What is it for anything, for that matter, to fall under the authority of medicine, to fall under the jurisdiction of medicine, to be the doctor's job to deal with? And so one way of making that question a little bit more concrete is to think about it in the following terms. There are all kinds of, just call them mental health conditions, psychological problems that can be distressing or disturbing. They can be distressing to me having them, or they can be disturbing to other people to witness. So hearing voices can be distressing to me, disturbing to other people. Feeling sad for no reason can be distressing. Having a very difficult personality, like I can't hold down a job, that can be distressing. Losing interest in sex. Suppose I'm 70 and I just start losing interest in sex. That can be distressing and disturbing. Drinking too much. Feeling anxious about a job interview. Feeling guilty about yelling at my kids for no good reason. The pain of unrequited love, loving somebody who doesn't love you back. If a friend starts to believe in conspiracy theories, this can be very disturbing. Being shy can be very distressing. So you have a whole host of things that are distressing and disturbing, yet only some of them are generally deemed to be medical problems. Only some of them fall under the authority of medicine. Only some of them are seen as being the doctor's job to deal with. And so that raises a puzzle. What exactly must be true of one of these conditions in order to make it a medical problem, in order to make it fall under the jurisdiction of medicine? Now, it's true, as some people might be quick to point out, that the boundary between what society sees as a medical problem and what it sees as a non-medical problem tends to shift from time to time. That's true, I recognize that, but any particular generation will have a rather firm sense of what counts as a medical problem, what doesn't count as a medical problem. And so we're still owed an explanation for what makes something a medical problem, even if the boundary shifts a bit from time to time. Now, here's one particular thought you might have, and it's one that I think is false, but I'll put it out there just to give you a contrast. You might think it's something like this. Perhaps you can align all of these different conditions I've described in terms of a spectrum of disturbingness or a spectrum of distressingness. So, for example, being shy is less distressing potentially than hearing voices that seem hostile or strange. And you might think that as these conditions increase in their level of distressingness or disturbingness, there's a certain threshold, and after that threshold, they become legitimate medical problems. But that strikes me as false. I don't think that particular way of thinking about medicine works. I can say from my own experience, I was hospitalized for depression as a teenager. I've also experienced more recently the pain of unrequited love. And for me, I think that the pain of unrequited love is much worse than depression. I would take depression any day over the pain of unrequited love. Yet at the same time, it's generally depression that we see as the medical problem. The pain of unrequited love, just a normal and perhaps unfortunate response to a pretty ordinary circumstance of life. So my point is that it's not just how intensely distressing something is that makes it a medical problem. Something else has to be the case. And here's my viewpoint. It seems to me that what makes something a medical problem doesn't depend so much on the character of the distress. It doesn't depend on how intensely distressing it is, but rather it has to do with the nature of its cause. And specifically, it seems to me that what makes something a medical problem is that it is seen or believed to result from what I'll call a violation of a norm of nature. And I don't love that expression, but I can't do better at present. So let me explain what I mean by this admittedly vague notion of a norm of nature. The idea is something like this. We all have this vaguely shared idea that there are certain ways that the body and mind are supposed to work. The heart is supposed to pump blood, eyes are supposed to see, hands are supposed to be able to grasp things. And we have this idea, moreover, that these norms aren't issued by society, but somehow issued by nature itself. In other words, nature itself, as it were, declares that there are certain ways that the body and mind are supposed to work. But of course, sometimes things don't work the way that they're supposed to work. And those are the kinds of problems that medicine has authority over. So the basic picture I have in mind is something like this. What makes something fall under medicine's authority is not the fact that it's distressing or disturbing, or not merely the fact that it's distressing or disturbing, but that it's caused in the right way. It's caused, again, vaguely understood by something like a violation of a norm of nature. And I won't spend a lot of time on this, but there are three main lines of evidence that have led me to this conclusion, that what makes something a medical problem is that it stems from a violation of a norm of nature. First, this conclusion comes from just reflecting on the ordinary presuppositions of medicine and the way that we talk about medicine, both professionally and in everyday life. That's the only thing that I can think of that would actually distinguish the things that people take to be medical problems from things that people do not take to be medical problems. Secondly, psychiatrists often do appeal, again, somewhat vaguely, to this notion of a norm of nature when they're talking about mental health problems. So, for example, to describe depression as the result of a chemical imbalance is to suggest that there's a certain way that our brains are supposed to work. And in the case of depression, our brain is not working the way that it's supposed to. And finally, and then I won't dive into this, but I have a lot of historical evidence for this view, namely that whenever doctors are arguing with other people about whether or not a certain mental health problem falls under their jurisdiction, historically, they've often appealed to the idea of a norm of nature to justify why a certain mental health condition does, in fact, fall under their authority. So again, in short, it seems to me that what makes something a medical problem, what makes something fall under the authority of medicine, is not the character of the distress, or not merely the character of the distress, but that it's seen or believed as stemming from the violation of a norm of nature. Okay, so with that background in mind, I can finally revisit my thesis and then start wrapping up. If I'm right that what makes something a medical problem is that it arises from a violation of a norm of nature, then what I'm calling this madness as dysfunction point of view really isn't incidental to psychiatric thought, but somehow constitutive of it. To put it differently, it seems to me that if I genuinely believe that a certain mental health condition is not really a dysfunction at all, but that it's a perfectly functional response to an ordinary life problem, then I don't think it's a medical issue. I don't think that it falls under the jurisdiction of medicine any more than getting, anxious about a job interview. But if I don't think that, say, depression is a dysfunction, if I don't think that it falls under the jurisdiction of medicine, then what I'm saying is it's not an issue for psychiatrists to deal with. It doesn't fall under their authority any more than my getting anxious about a job interview falls under the doctor's authority, or my feeling guilty about yelling at my kids falls under the doctor's authority. Again, if I really thought that depression is the mind's functional response, which is an attempt to show me that something in my life isn't going well, then what I'm claiming is that it's not a medical issue. It's not something for the psychiatrist to deal with. That doesn't mean, of course, that we shouldn't give people resources to help them. It just means that those resources, those treatments, don't form part of psychiatry proper. Okay, so that's a lot to say. Let me just raise one particular worry or one particular objection before I close. And the idea is this. Some people say, look, Justin, you have a very narrow idea of, the authority of medicine. Yes, doctors do treat diseases. Yes, they do treat pathologies, but they treat a lot of other things besides diseases or pathologies. They treat plenty of things that aren't, strictly speaking, dysfunctions. Doctors treat severe pain with morphine, even though they don't think that pain as such is a dysfunction. They think it's your body's designed signal that something is wrong with your tissue. Doctors perform cosmetic surgery. They can help me get rid of wrinkles around my face, even though they don't think that wrinkles are a dysfunction. They think of it as a normal product of aging. Doctors can help people end unwanted pregnancies, but they certainly don't think that an unwanted pregnancy is a disease or a disorder. So surely, one might say, if doctors can and do treat all kinds of problems that do not involve dysfunctions, then surely they would be entitled to treat problems like depression, anxiety, or psychosis, even if they did not think of those things as being dysfunctional. So there are two things that I want to say in response to this kind of objection. The first response is just to note that society hasn't always let doctors perform these various kinds of procedures. Even in the 1600s in the West, most doctors did not think that their job was to alleviate pain. For example, they did not think that their job was to alleviate pain, but rather to treat the underlying diseases that cause the pain. Until recently, performing cosmetic surgery or certainly ending unwanted pregnancies was not thought of as being part of the doctor's job or as medicine's jurisdiction. So these are not uncontroversial examples of things that are the doctor's job to deal with. But even in those cases where we're willing to grant that it is the doctor's job to treat severe pain or to perform cosmetic surgeries or to help end unwanted pregnancies, I think as a rule, they wouldn't do it if they thought that condition was benefiting the patient in some important way. So take pain. Suppose I break my leg, and suppose I'm experiencing severe pain. The doctor is going to hopefully treat it with morphine. It seems to me that they only do that because they think that that severe pain is not useful for me. It's not beneficial for me. It's not performing some important healing function. It seems to me that if doctors really thought that the pain associated with a broken leg was performing some crucial part of the healing function, then they wouldn't be inclined to treat it. Similarly, I mean, it seems kind of silly to think about, but it seems to me that if doctors really thought that, having wrinkles had some healing or had some healing powers for the body, then I think generally they would not be inclined to perform cosmetic surgery. So my point is that it seems to me that doctors are willing to carry out some of these procedures, like alleviating pain or performing cosmetic surgery, only to the extent that they feel confident that these conditions are not performing some useful service for the body. So I think that if you genuinely did think that depression has some important function or that it performs some useful benefit, that it's, say, your mind trying to tell you that something in your life isn't working out well, or if you genuinely thought that psychosis was something like your mind's attempt to buffer you from some painful reality, you still would not be inclined to let a doctor treat it. So it seems to me that the kind of considerations that would lead doctors to treat things that aren't dysfunctions, like severe pain or wrinkles on my face, those kinds of considerations would not justify doctors treating things like depression or anxiety if they thought that those depression or anxiety was functional or beneficial in some way. And with that, that's all I have. Thank you very much.
Okay, thank you, Justin. So we can have discussion now, and please put up your hand or your question into the chat. So Sophia, I think Sophia is first. Please.
Yeah, thank you. As you probably know, I like your book overall, but I still think we should embrace some kind of pluralism about this. And so one reason is that I think what's termed psychiatric conditions, it's such a sprawling landscape. People are so different, and I wouldn't want to commit to like everything serves a function. But second, even if something is at bottom functional, it can also turn harmful, right? So from like physical medicine, the easy example is a fever. You get an infection with some pathogen, you get a fever, it helps slow down pathogen reproduction, so it serves a clear function. But if it rises above like 42 degrees or something, I have no idea what that is in Fahrenheit because I'm a normal person. So it uses the metric system like 99% of the world. But anyway, there is like a limit where it can actually do neurological damage if it continues to rise. So you got to take fever suppressants for preventing long-term damage at some point. And I really think, for instance, insofar as psychosis can serve a function, it's really like that. I don't think it's good, probably, at least not in most cases, to go through too much raw sheer terror. I don't think that's going to be healing. It's going to be, at least in many cases, more like having 43 degrees fever, which is bad for you. And so I think there can be a lot of cases like that.
Yeah, thank you. And I appreciate your being here. Thanks so much. Let me, I didn't get a chance to talk about this, but let me come back to depression, because that's something that I think there's a plausible case that to be made that depression. So think of it this way. I mean, there's a lot to think about. Suppose you thought that depression was functional. And by the way, I'm not saying that all the things that we call mental health problems are functional. I'm trying to say what I think would follow if you thought of a particular condition as functional rather than dysfunctional, and how that would, I think, put into question medicine's authority over it. But depression is a good example where even if you think that depression is a functional response to a life problem, your brain designed you to get depressed from time to time for the benefit of helping you to see what in your life isn't going well. Maybe you need to detach from an unrealistic life goal, and depression is your mind trying to tell you that. Even if it's functional, then in my view, there will be dysfunctional variations on it. Anything that's functional, I take it, can break down and become dysfunctional. And so I take it that still the doctor would have the job of kind of monitoring it. And certainly if it became dysfunctional, they would either have the job of monitoring it and preventing it from becoming the dysfunctional variety of depression, or coming in and helping out if it does become the dysfunctional variety of depression. Now, I think one response people might have is that, look, okay, now you're multiplying all these forms of depression. You're saying some are functional and some are dysfunctional, and it's too confusing. But I don't think it's a bad kind of confusing. I think it's a really medically productive kind of confusing. It's good to know, for example, when pain is functional and when it's dysfunctional. It's good to know when pregnancy is functional and when it's dysfunctional. So I think that, if anything, being more clear about when, say, something like depression or psychosis is functional and when it's become dysfunctional, like fever, would actually benefit medicine a lot. And it would also prevent what I see as a lot of harms associated with medical framings of things that aren't medical problems. So I think more nuance and more breaking things down into functional and dysfunctional variants is good for medicine and good for people.
Yeah, that I agree with very much. Thanks.
Thank you.
Okay, next is Scott.
Yeah, thank you. Hi, Justin.
Thanks,
really appreciated your talk, and and I'm highly sympathetic to the overall thinking here. But I did want to add, and the previous questioner got at some of what I was thinking about, but I guess I did want to add a little bit to your final worry, which is to say a couple of examples that are a little different from the ones that you raised, and that might or might not warrant a somewhat different approach to incorporation into your overall argument. The first is from infectious disease, like the previous questioner. There are a lot of elements of what makes infectious diseases important to physicians, and the pathogenesis of infectious disease often entails, as a very central aspect of them, the immune response to the organism. And fever, certainly comes under that heading, but there are many more. And it's often the case that the most serious effects, adverse effects of having an infection relate to the immune response. Now, clearly, we'd be in big trouble if we didn't have immune responses, and infectious disease doctors maybe don't spend. Maybe this is one answer to this. That maybe they just don't spend enough time thinking about, well, what aspects of what we're seeing is functional and what aspects is dysfunctional. But the problems of the immune response to infectious agents aren't just incidental to infectious diseases. They really are constitutive of infectious diseases. My second example, I sort of see as an analog to your distinction between depression, quote unquote, for no reason, and the aftermath or the context of unrequited love. And that is from orthopedic surgery, the concept of a pathological fracture, which I think is a very interesting one in the context of your argument. If you bump your arm and end up breaking your radius as a result, then there's going to be a big investigation as to why your bones are so brittle, and there are a whole lot of potential reasons for that. But bumping your arm against the wall and ending up with a fracture would be considered a pathological fracture, whereas if you got in a high-speed car accident and fractured your femur, that wouldn't be a pathological fracture. That would happen to anybody, and yet an orthopedic surgeon would consider it no less in his bailiwick or her bailiwick to address, what could be a very dangerous fracture of your femur, even though it's completely understandable that it would have broken under those circumstances. So I kind of think of the latter as, sadness in the context of unrequited love that has gotten to the point of being immobilizing, so that, for example, you're unable to go out and find a replacement for your unrequited love, or whatever the analogy might be. So I wonder if folding in those examples into your final category of worry, changes your thinking on any of this.
Yeah, thank you. I mean, that's really a lot to it's a lot to think about. So I appreciate that. I'll just say something about the first part because it's easier to respond to. No, but I mean, as far as you talk about immune responses, and I take it that part of your point is that functional and dysfunctional things can interweave in very complex ways. Something can start. I mean, a medical problem can involve a complex interaction between functional and dysfunctional processes, like immune responses. There can be some initial dysfunction, and then the immune response can be a functional adaptive response to that. But then that, in turn, in some cases, the immune response can go on to create further problems. And so, and I'm definitely, I mean, I think doctors need to be very aware, just like what I was saying to Sophia, not just aware of when something is of the functional variety and when something is of the dysfunctional variety, but the way in which function and dysfunction can intersect in complex kinds of ways. So one thing that people, I don't know if it's true or not, but sometimes people say this about delusions. They say, well, what happens sometimes is that there's some perceptual abnormality. Somebody hears things or sees things that aren't there because of some kind of a perceptual dysfunction, some dysfunction in the sensory gating mechanism, or whatever the explanation is. And then in that person's effort to come up with the best, most credible explanation for what happened to them, they might come up with something that seems pretty delusional. For example, that they're being watched, or that there's spirits around them, or something like that. And so that could theoretically, I'm not endorsing this could theoretically be an example of how a primary dysfunction and a functional response work together to create a full-blown syndrome. Even there, though, I would just say two things. One, it's still absolutely pivotal, I think, for doctors to understand, okay, which one is the dysfunction and which one is the functional response to the dysfunction? Because if they blur those things, or if they get confused about those things, then they might target the wrong thing. So they might think that the delusion is the problem, when actually it's not the delusion that's the dysfunction, it's the delusion that's the functional response to the dysfunction. But yeah, I hear what you're saying. So as I see it, you have madness as strategy kind of framings. You have madness as dysfunction framings. In some cases, the best explanation is going to involve some kind of hybrid of both of those things. And then I still think it would to that extent fall under medicine's jurisdiction.
Makes sense. Thank you.
Thank you.
Okay, next question from Stefan.
Thanks. So thank you for an excellent and thought-provoking talk, and your work in general, both recent and previous one. I really appreciate it. So yeah, some of what I was going to ask was asked by Sophia and Scott, but I have two quick questions. One is, basically what you've argued now in your answers is something that perhaps looks like the pluralistic approach which you started with, which I personally subscribe to, as you say that psychiatrists may have a role actually in preventing the dysfunctional variety of the let's say depression. And this is one thing that I would like you to tackle if possible, but also maybe more importantly, as you say, psychosis is basically a historical paradigm for psychiatry in general, especially as a medical specialty. I don't know if you agree. So I think maybe this is the more controversial case with delusions, as you've described. And so you argued that we might look at delusions as a strategy, perhaps as providing meaning to a person. But you also argued that we should not treat it as a dysfunction, but maybe we should provide another strategy for meaning making for such a person. So my point is, isn't that another way of saying that we actually do need to treat it by providing an alternate frame for that person? You know, and isn't that, you know, with whatever approach, you know, I guess that something that's not thought of as problematic is psychotherapy, for example, logotherapy from Viktor Frankl. But as we are both biological and psychological beings, like intertwined, why would taking medication be a more problematic way of providing an alternate strategy?
Yeah, I mean, those are all great questions. So I'll try to, answer some of them. I mean, they're all really good. I'm going to stick with depression now because I think there's such a strong case for it, and I'm using it as a paradigm to start thinking about more difficult cases like psychosis. But so depression, let's suppose the evidence looks like this. Most of what we call depression is actually functional. It's your brain's design signal that something in your life isn't going well, and that the right thing to do is to help the person figure out what's going on, potentially use drugs if it is to the point where they just can't leave the house. So that I'm absolutely for using drugs in some extreme cases where you just need to in order to help the person live well. And let's assume that there's a small number of dysfunctional cases of depression that comes as a result of, say, brain damage or deteriorating brain processes. So I still want to say that profound harm would come about, and I think does come about, by framing the functional variety of depression as if it were a dysfunction. And as I'm seeing it, as I'm using the term, as if it were a medical problem, I mean, I think that there are well-documented harms of framing something as a dysfunction if it's not a dysfunction. And I won't, repeat them all, but I'll just go through them. I mean, quickly. Dysfunction-centered framings tend to make people feel more stigmatized about their condition. They tend to make people feel more pessimistic about their condition. They tend, at least in some studies, to route people toward medication and away from therapy, particularly when we're diagnosing diseases or disorders in children. We can potentially mistake a rather kind of ordinary part of childhood development as if it were a disease or disorder, and that could be very harmful in terms of giving a young person an identity as having a mental disorder and potentially putting them on a long-term use of prescription drugs that could have damaging effects on their development. More philosophically, seeing something as a dysfunction when it's not really a dysfunction could negatively impact our broader social response to it. So, for example, if depression, really is a pretty coherent functional response to a life problem, and we mistake it for being a dysfunction in the individual, that could totally throw off the way that we, as a society, choose to respond to it. So that's the context, is that I do think that there are profound and powerful harms with framing something as a dysfunction if it's not really a dysfunction. But I want to be open-minded in this, and I take that, sorry, let me just say this, I take that to be equivalent to medicalization. So what I'm kind of arguing here is that seeing something as a dysfunction is effectively the same as medicalizing it, as seeing it as a medical problem. So I want to be pluralistic in terms of the explanations that we're willing to give. When we see something like depression or psychosis, I absolutely want to be sensitive to, okay, is the best way to see what this person is experiencing as functional or as dysfunctional or as neither? I think it's really important to be able to construct these, as you put it well, these alternative meaning-making framings for thinking about people's experience. So no, I don't want to be wedded to the idea that all of the things that we call mental health problems are really functional rather than dysfunctional. My main goal is to think about what would follow if we really did believe this in any particular case, that somebody's depression is functional or that somebody's psychotic episodes are functional. What would follow from that? I think it would take us outside of medicine and outside of psychiatry, still needing healing, still needing treatment, but needing some very different kind of treatment, needing very different kind of healing, because we are generally talking about things that are extremely distressing, can be extremely disturbing, can be extremely disabling in some way. So they still merit some kind of response. I'm just not sure that medicine would be the right response. That was a lot to say, though, so I apologize if that was something about just ideas tumbling out.
It was great. Thanks.
Thank you.
Thank you both. And we have the next question from Alexander.
First, thank you on wonderful presentation.
Thank you.
I have two quick comments on it. In your talk, you mentioned Freud and psychoanalysis.
Mhm.
I think that your thesis that madness is not dysfunction, but some kind of strategy is in line with some ideas of Carl Jung, for example. Jung saw depression as caused by some problem that person found in his life that cannot be solved by a conscious, rational way of thinking. So it's stuck. And then depressed come like some kind of incubative state that during that there is regression on other way of thinking, some unconscious, intuitive, imaginative way of thinking, and person trying and that is for Jung, that is psychosis. And with help of psychosis, person trying to solve problem that cannot be solved with ordinary thinking. What do you think about that idea?
Yeah, I thank you. I think that Freud and Jung and a lot of their psychodynamic followers, one thing I respect and value about the tradition is that, I'm not sure if it's right or not, but one thing I respect and value about that tradition is that they were very much willing to see strategy, purpose, design in what we would often see as dysfunction or medical problems. And I love that Freud sometimes even criticizes his medical colleagues. At one point, he's talking about delusions, and he says something, I don't remember the exact line, it's in my book somewhere, but he says something like he's frustrated that so many of his medical colleagues can only see disorder where he can see design. That didn't mean, of course, that it wasn't something that needed to be treated. It absolutely did. But he thought you needed to first understand what unconscious strategy was being played out. Or for Carl Jung, you needed to understand how the different components of the self were trying to communicate with one another and to, ultimately create a more kind of harmonious whole. I think that's a theme that you see sometimes in the internal family systems therapy, where you see these different, or even from what I understand, sometimes in the hearing voices network where you look at the mind as having these different components that are trying to talk to one another. So I do, one thing I admire about the psychoanalytic and psychodynamic traditions is certainly willingness to think about things outside of the dysfunction framing. And even if we don't accept specific of their theories and ideas, I think that the idea of function, strategy, design is still a really important notion going forward. And it has more credible, I think, scientific expressions today.
Thank you. My second comment is, I think last summer there was some interesting study that make like big controversy in psychiatric cycles. It was study of, I think name of person was Joanna Moncrief, that there is no correlation between depression and the level of serotonin. It was like big hit on all that theory.
Mm-hmm. Yeah. I actually interviewed Johanna Moncrief about 2 weeks ago for I have this blog for Psychology Today, and I did a follow-up a couple of weeks ago with her just to see how kind of her reflections on some of the criticisms that she got for that paper and how she responds to some of the objections. And I think it was an absolutely important paper for reasons that I can't possibly go into, but for reasons I agree entirely with her analysis and what we talk about in the interview, that in the 1980s, and I was put on Prozac in 1989 or 1990 or 91, pretty much as soon as it came out, a lot of us were put on Prozac. And a lot of people don't realize that at the time that was sold to us as reversing a known chemical imbalance having to do with serotonin transmission. People don't, I think, today appreciate the extent to which that was marketed to us and promoted to us as we are reversing a known dysfunction. Your depression is no different, in essence, from diabetes. And so I think that if you take that away, if you say, okay, actually, we don't have good reason, we don't have compelling reason to think that depression actually stems from a serotonin imbalance. We have some speculative theories about what it might be, but we really are totally in the dark about what depression is or why antidepressant drugs seem to work for a small number of people. If you take that away, you're removing a central ideological pillar from medical psychiatry. And I think that a lot of psychiatrists understand exactly what she was trying to do. And I think their reaction, their kind of visceral reaction that you saw among a lot of psychiatrists was a signal that they understood exactly what the stakes in this were.
Thank you very much, Ignatius.
Thank you.
Okay, we have another question in the chat, so I'll just read it by Miriam Solomon. And she said she enjoyed the talk and has a question. And the question is, evolutionary medicine is premised on the idea that much disease is functional. Do you think it is a non-starter in medicine as practiced in our culture?
That's a really good question. So if one of the premises of evolutionary approaches to psychiatry is that a lot of the things that we think of as disorders are actually functional, adaptive, depression being a primary example for the evolutionary psychiatrists, ADHD being another example for the evolutionary psychiatrists. Sometimes some of the things like BPD, or what are described as personality disorders, being another example where, and I should say, I do respect and admire this viewpoint of evolutionary psychiatry, not necessarily because I endorse every one of their explanations. I think it's very hard to get to the bottom of what's actually going on from an evolutionary point of view, but I do admire that they are helping, even inadvertently, to come up with these alternative kind of meaning-making frameworks for thinking about these mental health problems. I think it absolutely is clinically relevant. And again, I'll stick with depression because I think you can build the strongest case for that. A friend of mine who was a psychologist and professor of psychiatry, Hans Schroeder, recently did, I think, a very important study where he presents these two different kinds of framing to people who have experience with depression. He found about 800 people, 400 of them, they watched an informational video that depicts depression as a chemical imbalance. The other 400 people watch a video that depicts depression as effectively your mind's designed signal that something in your life isn't going well and needs more attention. And what he found was that the people who were exposed to this function framing had therapeutic benefits. Again, this is not a huge study, but 800 people is not negligible. They felt more optimistic about therapy. They felt that their depression might have some useful insights to give them. They felt less stigma about talking about their depression and sharing their depression with other people. And so one thing I've talked about with Hans that I think is very interesting is how do you incorporate this into actual clinical practice? Because a lot of clinicians almost make it seem as if it's just so complicated and confusing. Look, just throw the drugs at them and see what works. But one idea, and it's his idea, not mine, is in the same way that you prioritize various kinds of treatments in terms of their level of invasiveness, if you're not sure whether a particular person's depression is functional or dysfunctional, one way to do that is just to prioritize interventions in terms of their invasiveness. So begin with the assumption that this is their mind's functional signal that something in their life isn't going well. See how that works. See if that gives the person a sense of relief from their problems. If that's not working, then go to a next level of intervention, so medications. And so I do think that these have real impacts on intervention, and they actually do lead to relatively well-structured strategies of intervention.
Okay, thank you.
Thank you.
If we don't have any more questions, nothing for now. So I would like to thank Justin for this wonderful talk. And I would like to thank everyone for a great discussion that we had, for great questions. Hopefully, I will see all of you again for some of our next presentations in our seminar. So thank you, Justin, for accepting the invitation to do this presentation here with us and for putting forward all these very controversial and interesting questions that will need to be thought about by both philosophers and psychiatrists and clinicians, first of all, who will have to take this all into account. So again, thank you
so much, Janko. I appreciate that. I appreciate your inviting me.
Thank you all, and see you hopefully again.